Dr. Ryan here. I'm a board certified specialist physician. Thank you so much for joining me, even as we look at a systematic approach to dermatological or skin disease. If you haven't yet subscribed to my channel, I strongly encourage you to do just that. So this is not by any means an approach to a comprehensive overview of skin lesions. I think that would be impossible within a short space of time, but this is just to give us a conceptual overview of the common skin conditions we see, especially on rounds in internal medicine. Okay, so a good idea is to introduce yourself to the patient, position the patient, usually supine or semi-fowlers, or maybe sitting up, and obtain adequate exposure. Then you're going to inspect the entire skin surface, right? We're looking at especially the hair, the finger and toenails as well. Don't forget those. Examine lesions with a magnifying glass if needs be. Okay, first up, assess the distribution of the rash. Is it symmetrical? Is it over light exposed areas, which probably implies some degree of photosensitivity? Is it dermatomal? A classic example is herpes zoster, right? Over the pressure areas, over the flexures or extensors, or only the palms and soles. So first up, looking for the distribution. Then characterize the lesions. Are there macules, which means that it's not raised? It's visible but not raised. Papules, which means the lesion is raised, right? Vesicles, which means it is raised and appears to be filled with fluid. Is it bullae, which is a large vesicle? And are they purpura? Purpura speaks to, an assessment of bleeding into the skin. And if they are puffable purpura, which probably implies Henoch-Schwann line purpura. Right, so we said distribution, we said characterize the lesion, and look for specific kinds of lesions, like targetoid lesions, or Caffioli spots, or telangiectasia. Right, also, is it morbilliform, which means macular papilla, usually keeping company with some kind of drug reaction or some kind of viral exanthem. Is it herpetiform, which implies vesicular? Is it exfoliative dermatitis? You also want to look for scratch marks, right? Look for excoriations and polished nails. Is there any depigmentation that we can see? And you want to elicit the following signs: a Nikolsky sign, a Darrier sign, and a Kubner phenomenon. Right? We'll speak about those a bit later. Examine the scalp, especially looking for psoriatic lesions, or if there's seborrheic dermatitis, or if there's tinea capitis. Examine the oral cavity in the eyes, looking for ulcers, looking for scleritis and episcleritis. Look for lymphadenopathy, important. Check the liver and spleen, especially for Sézary syndrome. Genitalia, which, probably looking for ulcers or balanitis, which keeps company with reactive arthritis, any urethral discharge. And check for edema, urinalysis, check that out for proteinuria, for glycosuria, for those parameters. And does the patient have a fever, or is the patient tachycardic, which may imply septic skin lesions, right? Alrighty, so important questions on history for the patient with a rash. How long have you had the rash? The duration. Have you ever had it before? So history of the rash. Is it getting worse? What parts of your skin are affected? Like, is it just the sun exposed areas, most likely photosensitivity? Areas in contact with clothing or particular chemicals, which implies some contact dermatitis. Was the rash flat or raised to begin with, or was it blistered, right? So you know those deals right there. Is it morbilliform? Is it vesicular? Does it look like a bullous? Is the area itchy? Okay. Does anything seem to make you better? How has your diet changed recently, implying a link between a certain type of food the patient may be reacting to or may be allergic to? What treatment have you tried for it, right? In the way of antihistamines or steroid creams or antibiotic? Have you had a fever or any joint pains, which implies some rheumatological components? Have you had any problems with allergies, right? Are you taking any medications or tablets for these? Are any of these new within the last 6 weeks? Have you changed your soap, your shampoo, your deodorant, or your washing powder recently? What sort of work do you do? Do you come into contact with chemicals at work or with your hobbies? Have you traveled recently, and if so, where to, implying an infectious cause? Has anyone you know got a similar rash, which may imply some contagious element? Have you had any other problems with your health? Right, nice one. Okay, we're going to hone into some specific examples now. Okay, so this is scabies, right? So we know that with scabies, we have tiny burrowing in the web space. So scattered fine papules with severe itching, finger web involvement is common, right? And here we have, let's get my pointer in there. So lichen planus, right, with polygonal, flat-topped, bilaceous or lesions. Right, so it's polygonal and it's papular. right? Pityriasis rosacea or Pityriasis rosea with scattered scaly oval lesions of the trunk and a larger so-called halo patch, which we can see here, right? Here we have lichen planus again with development of this so-called Koebnerization, right? This is development of lesions in an area of trauma called the Koebner phenomenon. So you can see this patient usually probably has some trauma, probably scratched there. And so we have lichen planus kind of infiltrating this area. So basically a skin lesion which occurs over an area of trauma, we call that the Koebner's phenomenon, or an area of irritation, right? This is nummular eczema, right? So we can appreciate here in this picture as typical scattered coin-like lesions, right? There we go, typical. So nummular means coin-like, right? And these are of indolent dermatitis. In picture B, we have nummular eczema, a close-up view of these typical lesions. Then we can see here and see again nummular eczema. This is psoriasis. The maximum used for psoriasis is a salmon pink on silvery scale. Salmon pink on silvery scale. So this is typical bright red scaly plaque with silvery scale over a joint. So you see psoriasis likes the extensors, doesn't it? And also psoriasis of the scalp in the hairline that we can see here. It also likes, the natal cleft as well. So watch out in those kind of discrete areas. This is the rash, the infamous butterfly rash of systemic lupus erythematosus. Note how there is sparing of the nasolabial fold, right? Erythematous butterfly distribution kind of on the malar area. But contrast this to rosacea. In rosacea, we have involvement of the nasolabial folds, and that's a way to distinguish and differentiate these two infamous rashes. Now remember that lupus has a variety of skin manifestations. So the acute, subacute, and the chronic. So the acute is a typical kind of photosensitivity in the malar rash. Subacute is a psoriasiform and your annular lesions. And the chronic is a discoid lupus. You also get your chilblain lupus and that. This is an example of discoid lupus that we can see here with hyperkeratosis and follicular plugging if you have to biopsy this and send it off. All right. Here we have acute widespread pustular psoriasis. And so different kinds of psoriasis that you get in the skin. We already looked at nummular. This is pustular psoriasis. Often the eruption, as we see here, is bright red with bizarre patterns and pustules predominantly at the margins. Here is pustular psoriasis involving the hands. Remember the typical psoriatic nail changes is pitting, hyperkeratosis, onycholysis, ridging, and discoloration. This is allergic contact dermatitis from over-the-counter topical medications rubbed over congested sinuses. So you can see some degree of periorbital edema, and you can see some erythema of the overlying skin. Here we have Stevens-Johnson syndrome. Stevens-Johnson syndrome represents a medical emergency or a dermatological emergency, often on the back of reaction to a certain drug. And I was stating, watch out for Bactrim. Bactrim is infamous to this, but also a reaction to certain organisms as well, viral organisms. And so we have involvement with the mucosa, right? You get maculopapular lesions, right, with areas of denudation. So sometimes it looks like the patient's actually burnt, right? But if we have mucosal involvement, we call that Stevens-Johnson syndrome. If you don't have the mucosal involvement, you may call that toxic epidermal necrolysis. Okay, here is bullous pemphigoid. Bullous pemphigoid, which we can see here, these large vesicular lesions. This is primary herpes simplex virus in an adult showing typical widespread distribution around the mouth, right? So this is herpes simplex virus type 1, which is herpes, oral herpes. And then HSV type 2, which affects the genital area. This is lupus pernio. One of the infamous causes of lupus pernio is sarcoidosis, right? Watch out for the leonine facies as well. Watch out for the saddle nose deformity. Right, erythema multiforme looks like targetoid lesions that we can see, nice round erythematous lesions. Classic iris or targetoid lesions with an essential area of hyperpigmentation, as we can see. Secondary to herpes simplex viral infection of the lips. Interesting, right? This is cellulitis, we can see, and all the characteristics of inflammation. Rubor, calor, dolo, tumor, functionalesa. Rubor is redness, calor is temperature, tumor is swelling, dolo is pain, right? And that's what we see here. Typical superficial kind of area with swelling and with redness and with heat, and it's exclusively tender. This is erysipelas on the back of staph infection affecting the face. This is Epstein-Barr virus infection, right? It's causing a mabuliform rash. This is after taking amoxicillin. This is viral exanthem maculopapular rash that we can appreciate there. Measles is a typical example. This is a particular rash, so pinhead kind of bruising or bleeding into the skin that we can see. Petechiae, nice and small. This is Keratoderma veneragicum, right? Areas of denudation on the palms and soles and also affecting the toes, often on the back of Reiter's syndrome or reactive arthritis. Right, this is molluscum contagiosum, our flesh-like lesions, kind of round. And a differential for this is skin histoplasmosis, right? And here we have Candida albicans. You can see the white film in the mouth. This is fungal infection. Usually happens in patients who are immunosuppressed. But watch out, it also complicates patients who have asthma, who are taking steroid inhalers. Right? And the way you differentiate this from oral leukoplakia, we spoke about this in times past. If you scrape it off, right, then you can't scrape off oral leukoplakia, but you can scrape off Candida albicans with some bleeding. And the distribution is that oral leukoplakia usually likes the sides of the tongue, the lateral aspect, whereas Candida doesn't really respect that. Right, this is tinea pedis, so this is basically ringworm infections or fungal infection affecting the web space here between the first and second toes. All right, this is metastatic melanoma. So now we're going into the malignancies. So you can see a nice, remember the A, B, C, D, E criteria, right? Asymmetrical, the border is irregular, usually the color is abnormal, right? And the size, the dimensions of it, and so this is, hyperpigmented, quite a large, significant lesion. This is actinic keratosis, which is slightly eroded and scaly on the scalp. This here is squamous cell carcinoma behind the ear. Okay, this is basal cell carcinoma. Note the rolled edges. This is nice rolled edges that we can see here. And here we have pigmented basal cell carcinoma in this image with pearly quality and depressed center in a patient who has sun-damaged skin. This is superficial spreading melanomas. There's different kinds of melanoma that we get. The nodular sclerosing, the acrolentiginous, lenticular right? So this is superficial spreading melanoma, still confined to the epidermis. And then, of course, here we have onychomycosis, which is fungal infection of the nails. Watch out for diabetes. Okay, my friends. The book of Hebrews, chapter 4, verse number 15, declares for us that, for we do not have a high priest who is unable to sympathize with our weaknesses, but we have one who has been tempted in every way just as we are, yet was without sin. See, Jesus Christ is our example because, yes, he was God, but he never used his powers as God to resist temptation on this earth. So he faced temptation in exactly the same way that you and I face temptation today. Classic examples: the temptation to become proud, the temptation to lose our temper, the temptation to lust with our eyes. Jesus Christ faced these and overcame them. So because he overcame, we can also overcome, because now we have grace. And Romans says that you are no longer under the law but under grace. Therefore sin shall have no dominion over you. So you see, when we look at Jesus' example and we access grace by the power of the Holy Spirit, then we can resist temptation. And therefore he is our high priest, and he is the mediator of a better new covenant for us, one where we are free from sin. These are my references, guys. Thank you so much for joining me. God bless you. I'll see you soon with our final video in the physician examination series, where we're going to be looking at a whole host of typical diagnostic phases. God bless.